So there are economic forces and there are technical forces, and yet this technology is in a good position. We're big advocates, and we'd like to share that advocacy with you. We do have one case which has been sent in by one of the attendees, and that'll be the fourth case we talk about. And we also want to point out that for future webinars, if you'd like cases discussed publicly, we'd welcome that. We'll provide you a mechanism for getting those cases to our attention so that we can bring them up for the next webinar. And today I'd like to demonstrate a reading style. So what you're looking at really is the splash page, the beginning page, and a list of the many cases that we've posted for use in our course and for use today. And I've selected one identified as coronary artery disease A09. And this is really meant to be a straightforward and a simple case, which I'll go ahead and load, and as I load, demonstrate and talk about some of the tools that come up. And we'll let these various tools run and let this case assemble itself. There's a good deal of computer processing which is going on in the background. And we first come to this space here, which is a typical rendering that you will see on a workstation, either if it's local to your work environment or if it's remotely accessed, as we're doing today. But we really have a 4-panel screen which illustrates color and grayscale renderings of this particular individual, who was about a 39-year-old male who had smoked and had risk factors established and had chest pains which were atypical. He performed a routine stress test which was normal, and instead of doing a higher order perfusion study, a more expensive study, bargain was worked out, so he had a CT angiogram performed. But really the question is do I have coronary artery disease or not? And I'll sort of work through the way and the routine that I would typically approach a case. And sometimes I'll utilize, in fact, I'll always utilize the direct axial images, which I'm moving over here in the upper left panel. And really the quick scan here is to address the issues of quality and to see if there really is any calcification in these vessels. The calcium score is typically always done, but we can be alerted first to issues in the left circulation. And let me see if I can bring into focus the left anterior descending coronary. And there it is, just there. And we see these speckled areas of calcification, which seem to be on the periphery of what would be the left anterior descending coronary. We can look at this in a higher degree of magnification. We will need to look at this in detail because there's obviously a generous amount of atherosclerosis here. But really what I'll do is go ahead and demonstrate some of the reading tools that you may or may not choose to use, but are quite handy and are part of the computer processing that runs in the background as these cases are loaded. Let me go ahead and point out that I like the orientation here, and the first question I'm asked is whether this is a good representation of the primary vessel, and here we have the left anterior descending. Readers that typically don't use this for more than a sort of a lay of the land 30,000 degree view of the coronaries, but it's clear that there's quite a bit of irregularity and stippling to the contrast pool here. I'll go ahead and validate, however, that I like that particular presentation. This is a good look at what is typically the circumflex, and I think this is probably a bifurcating single circumflex marginal here. I'll click to validate that. This is now an RAO view, which we process to by the pathways that have been established by the computer, and I'll validate that. And then in the background, I'll let this run, and an automated center line has been drawn. And this has been outlined here, and there are certain measuring positions that we may or may not choose to use for our purposes today. I'm going to turn these off and just expose what we call a curved planar reformation of this image. In other words, the raw data has now been taken, and we have something akin to a map of the globe which has been pressed into 2 dimensions. So we have something which is not anatomically faithful to adjacent structures, but is really the entire course of the right coronary artery laid out here for us to view. And by sweeping the mouse back and forth, I can pick up an area of calcium here and an area of calcium here. And I think attendees watching, if you've seen any CTAs, we'd recognize that this is simply mural calcification. It's certainly disease, but it's not bulky. There doesn't appear to be any associated soft tissue density that would indicate non-calcified plaque. So this would be a focal proximal right coronary artery calcification only, but probably of a non-obstructive nature. In fact, almost certainly of a non-obstructive nature. So let's go ahead and jump to the next vessel, which is the left anterior descending. I don't really like the center line that's been drawn here because actually as this algorithm is run, it's sort of dead-ended up into here, part of the right ventricular outflow tract. And that's really just seeking in the presence of a little bit of artifact that we can obviously recognize. But the proximal port of this vessel has been nicely rendered. We probably have the distal part of the beginning of this center line originating in the ascending aorta. So I'll go over and look at this same vessel. And this was the vessel that we saw in the axial images when we originally looked at this study. By the way, I can fine-tune the window and level and everything as I like, but this is defaulted into a pretty good view. And what I see here is worrisome because there's a lot of disease. There's both calcified and uncalcified plaque, I believe. Some of these areas here, I think, one could even argue that there may be some ulceration in some of this plaque area, but really the left anterior descending right about at its origin and down beyond the first septal perforator, which is probably right here, we've got a generous amount of what looks primarily to be calcified plaque. Now, this body calcification is one of the features that we identify as characteristic, at least by CT criteria, of plaques which are likely to be vulnerable or have a higher frequency to end up as culprit plaques in later downstream clinical situations. So not to disparage the severity of this at all. I think this is a lot of disease. This is long-standing disease. But I think it's quite clear that this is not the sort of disease that would be likely to yield a abnormal exercise treadmill test. In other words, it's not likely to be a flow-limiting problem. Certainly, it could be the nidus of a very significant clinical event, particularly its positioning in such an important vessel. But this is a plaque which, in terms of stenosis severity, should probably be graded as mild, and that is it's likely to be less than 50% in a diameter severity. Let's go to the next, so I'll go ahead and validate this, and let's go ahead and look at the circumflex, a large vessel, and single mouse clicks will typically bring that into view. And I'll go ahead and click on the vessel that I like. And with the same techniques, we can go ahead and find a rendering. Both of these vertical windows over here are multiplanar reformatted images that happen to just be stretched onto a single two-dimensional surface. And we're looking at two opposing 90-degree angles. And this particular technique is nice because we can pirouette around the vessel just by sweeping the mouse. And again, we see that there is calcium only in the proximal part of the left circumflex here. There's a little bit of a gray shadow accompanying this. That's quite likely to be artifactual. So I think this patient, in a summary report, should be characterized as having coronary artery disease of all three vessels, excluding actually the left main. However, it is non-obstructive and calcified only in nature. So this is a patient who doesn't need a further workup. This may be very clarifying in terms of understanding his symptoms, is quite likely to be non-cardiac. And I think we can sort of triage this patient into the correct treatment pathway without going on to a higher order, more expensive test or second and third opinions on the cardiology side of things. Okay, I'll leave that case now, and I'm going to return to the patient list here. And let's go to the next case that we've selected. We could pause at this point. I think, Rob, I'll let you be the judge of that as the moderator, but we can take questions if you like on this particular case, or move to the second case and see if we provoke any questions there. And if we want to hesitate a little bit to give people a chance to assemble a question or two, this would be a good time.
Carter, let's go ahead and just pause for a second and give, because we've got some things kind of coming in. So, and feel free to ask questions about the course, the company, and also the case review and software. Got a question from Dr. Stevens. He says, given that much calcium in the LAD, how can you be sure that there is not a stenosis at that point?
Well, that's a good question, and I think that's a question that has taken the experience of about maybe 7-8 years of CT angiography and good done by the researchers and everything. When you can see that much contrast-enhanced blood, which is, and get a view where you can see that much contrast-enhanced blood that is clearly different from the mural calcification that we see in the wall. By the way, we don't see the walls, of course. All we do is see the calcium that's there. But when we can see that much, and we also know that the calcium is creating an exaggeration in its apparent volume just by the nature of CT. This is called a blooming artifact. we just know from experience that that is not going to be an obstructive lesion. Now that patient may have had a calcium score exceeding 100. In fact, he probably did. And on a good calcium score study at lower resolution, just a non-contrast study, the apparent severity of that might have appeared even greater. But nonetheless, that's a study which we can do and read with a very, very high degree of confidence. And I would predict that this guy was actually cath. We'd see absolutely nothing there except fluoroscopically, maybe a few flecks of calcium if we look closely. So this is just surely a non-obstructive lesion. In fact, probably one which wouldn't even make the radar of a careful inspection of a direct angiogram. Dr.
Turner has a question as well. Would you recommend a baseline stress test for linear follow-up?
It's a good clinical question. Stress testing has its own shortcomings. I think if one wanted to be able to identify their exercise capability, come up with a Duke score, this patient would probably have a very favorable one. I think that what you would achieve by a treadmill test is documenting abnormalities that would be pretty safely considered false positives. In other words, that this patient had ectopy, if he had limited exercise tolerance, things that at a later time might be considered abnormal. It might be a good idea to identify those now when you feel very certain that whatever findings you came up with on a stress test, they were very low likelihood of being associated with a coronary stenosis. So yeah, there's value in a stress test here. It's an inexpensive test, tells you stamina and tells you the unique characteristics of that particular patient that might otherwise be later misinterpreted. But actually, the problem is that much plaque can grow and can change, and so I don't really know what your confidence interval if the things are going to stay absolutely the same. So you wouldn't want to draw too much confidence with the CT information that you have or the stress test information that you get. So I think it would have debatable value.
Okay, and Carter, we also have another question from Dr. Faruqi. He asks, do you manually correct incorrect vessel tracking illustrated by this case, or has enough clinical information been gained?
I think we've gained enough information, but I do think it's very easy to correct misinformation. And I don't want to, I'll tell you what I'll do. I'm actually in the process of loading this case back up, but that's a great question. And let me just roll it over to the next case. And we'll do some correction on the next case and sort of show how that can be adjusted. A lot of these corrections, by the way, are really meant to be done, or can certainly be done by support personnel, the CT technologist or the image extenders that may exist in the lab. And so part of the nice thing about this is that people can go ahead and prep these studies for your review and really save you quite a bit of time if you don't want to spend the time to go ahead and do the editing yourself. Let's go ahead and close this out, and I'll take that question up. I think I'll get a chance to on the next case. All right, so if I've got the microphone back, let me go to a higher order test. This is a more complicated patient, and this will be CAD09. I'll highlight that, load the case, and while this is loading, I'll tell you the clinical story, and this is a patient seen twice. This is a premenopausal woman who had risk factors in her family history and was concerned about heart disease, really had nothing else working against her. Cholesterol profile was favorable. She didn't smoke, etc. Wasn't a diabetic. Not particularly active and a little bit had been on the heavy side and had lost some weight, but was worried because she'd had some chest pain that was unexplained by a couple of emergency room visits where her EKG and enzymes were normal. So she was sent out to see another physician to work this up. And this study was done about 3 weeks after she'd been to the emergency room and worked up without actual stress testing. And I'm not sure really why this was ordered in lieu of a stress test or instead of a stress test. But let me jump sort of right into these issues here. I went through these a couple of days ago, and this centerline analysis on good data is really pretty good. So let's go ahead and try it here. I'll validate these orientations. Again, this is validation for the typical good view of the circumflex, and this is typically just a left sagittal view. And the right coronary artery is really just an RAO, practically a right sagittal view here, and I'll validate that view. We can see this very twisted, turny, serpiginous view of the right coronary artery. And having seen that, let's go ahead and I'm going to rotate this around and convince myself that that's a pretty good rendering of the right coronary artery, and I think it is. And I'm not convinced it makes it all the way into the ascending aorta, but let me look over here at the curved planar reformations that have been drawn for us. And yes, so we've got, and this is a sort of anatomic distortion that takes place when you squash a volume, a 3D structure onto a 2D surface, but let's not get tangled up in what this looks like, but we can see that we've got the orifice to the right here. So I'm going to go ahead and confirm that I like that rendering and that particular curved planar reformation. And what about this left anterior descending here? I think that looks good. We've got the apical wraparound vessel, so it was more successful this time than that time, but I notice that this diagonal doesn't appear to be connected anyway, so we'll see if we'll experiment with that to try to answer one of the earlier questions. I'll go ahead for the time being and validate that view of the left anterior descending. And now we have the left circumflex. And sometimes the circumflex is difficult to tell from their venous structures over here as well. But that's selected what clearly appears to be a big marginal. There appears to be another vessel here. This may be an intermediate vessel, perhaps an early diagonal, but what's been outlined here looks clearly like the circumflex. I'll validate that. And then I'll go back to these renderings. Let's go back to what's been said. And let's just go ahead and use these curved planar reformations. They're very useful. They've been done nicely. And I think the difficulty here, and again, I'll turn off these little mask and assistance overlays so we can just look directly at the vessel, and I'll magnify that up a little bit. And this is, again, a very badly diseased vessel. I can see plaque, and maybe this is as good a view as any. There's a lot of calcium here. Things look a little fuzzier than they did in the previous study, and that's probably not a matter of the fact that the artery surfaces themselves are any different. But there's certainly a great deal more plaque, but I think this fuzziness is more of an issue of technique and perhaps the settings that were used to generate these images. There may have been a little less energy put in. But I think the most worrisome area here is not necessarily where we see all this calcium, because I can be convinced that there's contrast material in here. But I think this spot over here looks very disturbing. And frankly, when I was going over this study yesterday, I don't think I even appreciated how bad this segment of vessel actually looks. So we're in the right coronary artery here. And I would, without taking a lot of time, I would go ahead and represent that this proximal 1/3 of this vessel has multiple areas. In fact, the entire segment appears to be diseased with both calcified and uncalcified plaque here. And I think there is so much trouble going on here that I really can't make a good determination about what's contrast and what's not. And I think there's a very high likelihood that this area right here is significantly obstructed. And how significantly? This could be moderate to severe. And so I would want to reflect the high likelihood that a lesion like this could be could easily cause a positive stress test or ischemia-related symptoms. In practice, I must be honest, I didn't really even, I was so busy getting ready to go to the next lesion that I didn't appreciate this. So we certainly have proximal dominant right coronary artery disease, which is likely to be obstructive, and certainly also very likely to have been involved in what might have been an unrecognized acute coronary syndrome. Let's look at the LAD, because that's my recollection where so much of this disease was before that I wanted to illustrate with this case. And I'm going to go ahead and magnify this area up, point out that, and let me drag it a little bit more to the center and hopefully highlight that for you. We've got a nice center line drawn through here. Typically the computer will not go ahead and help us that much if we don't have a good center line drawn. But we've got a nice area here. And I see why I didn't recognize that right coronary artery lesion so well, because this is in fact a different case than I really intended to load, but this is a great case to illustrate exactly what we were talking about before. There was a question from the audience about whether or not this degree of calcification could easily be read through. Could we be sure that there's not an obstructive lesion? And others in attendance who, and I know Dr. Adams and Turner are very experienced readers, I would feel quite comfortable in saying that I've got a view here that tells me that this plaque is not an obstructive nature. Now it's proximal, it's clearly in the left anterior descending, it's an important left anterior descending vessel, and there may be downstream disease, but at least at this very high priority position where so many of the clinically very noteworthy acute clinical syndromes develop, I think there's very low likelihood, and actually there's really not the suggestion of any uncalcified plaque here. So in distinction to what we saw on the right, this would be calcified proximal non-obstructive disease. And let's go ahead and move over to the left circumflex. And here's a vessel which, let's just look at what these curved planar reformations will tell us. And again, I'll take this, some of these mask and overlays off the picture. Here we have a segment of vessel that, if you look at it closely and let me magnify it up, it looks fuzzy, and another word for fuzziness like there is motion artifacts. So this is a segment of the vessel where, and really this is typically the part of the vessel where we get flummoxed and have a little hard time reading, and although this is not supposed to be moving very much, it often seems to. And even though this may look to you, if you're an inexperienced reader, or to others who are experienced readers, these are areas it's a little hard to put your foot down firmly, but I think I can say that there's probably mixed disease here. In other words, they're both calcified and uncalcified tissue elements which we can record, but I think it's highly unlikely that this would be an obstructive plaque. So we really have a disease of 3 coronary arteries. The left main has been spared. We have obstructive disease, very likely, in a very complex plaque in the dominant right coronary artery. We have calcified and non-obstructive disease in the left anterior descending coronary artery. And we have mixed density non-obstructive plaque in the proximal circumflex. Well, it's still in the AV groove, but and preceding what looks to be a sort of an intermediate-sized diagonal branch. There was a question about correcting some of these lesions. For example, it's a little troubling that this diagonal vessel over here, at least on the 3-dimensional images, didn't look good. And let's see if the computer picked this up. And it didn't. And if I wanted to go ahead and add and edit this out, I think I can go ahead and highlight this segment and then right-click and delete the branch below, and then take the leading edge, and let me sort of move this measuring area out and try to drag the leading edge down to the vessel that I would like to correct it to. And it's a small vessel, and I think what we're going to have to do is just say that this vessel is too small to really connect a pathway, or we could conclude, now we seem to have done it there. I must just sort of see if that's helpful. And I think on the curved planar reformation, we're really looking at this small, relatively small vessel here. And I think what I would say is that's a small diagonal. It's quite likely, given the extent of disease we've seen elsewhere, that it either wasn't imaged well, or in fact it is disconnected and filling via collaterals. But I don't even think I would include this in a report, since the vessel seems so small, and since we have very high priority lesions that are almost certainly going to lead to a cardiac catheterization of this patient anyway. So I think I might have run a little bit over the time that I'd allotted for this study, but I'll go ahead and I've said my concluding findings, and so I'll entertain some questions here, or we can move on to the next case.